a lot and a lot more and more of patients, then these questions come back always to my mind, and it was a good chance to go back and review what other part of world facing regarding this disease. So for that, when I thought how to start, I was thinking about celiac disease, and how did this disease start? And actually, that's take me to the history. And the history of the human or humanity was a long time ago. And when the people after the Stone Age started to think to improve their life, and improving was through the farming. And that times there was an area, they call it the fertile area or the fertile crescents, which is this area, the green one. And they call it that because it was an excellent place for farming. And it is, as you see, the Mesopotamia, which is mean between the river, actually were between the Furat and Tigris, or the Furat, Tigris and the Nile here. So this area was the best from the water supply, best from the soiling, best. This is the area actually started to actually cultivation of grains. And after that, this is spread to the West area, to the Europe, and reach actually to Britain just 4,000 years ago. That's the times the people start to have some disease related to these foods. And this is expected with always the new things in new life. You may have something new. For that, when we talk about who discovered this disease, the first we need to talk about the first one, talk about the disease and describe it. And I think this guy is the most important one in describing celiac disease. His name Artias the Cappadocian, and he's from Turkey. And if you see his area, it is near to the Fertile Crescent. So that's explain why he's the first one, because the people who first suffer from this disease. And after that, the history start or the more explanation about the disease. Different people try to describe it better and better, like the Vincent Kettler or William Hurley or others actually. Till the Samuel Gee, which is another well-known in celiac disease in 1887. He's from London actually, and he described it more clearly, and he called it celiac affection. And when they went back to see from where this name, it was actually the translation of the language of Mr. Aretius, which is also, he called it the same, but in his language. So that is the first thing. It was called the celiac affection. Then after knowing the disease, start to look for the treatment. And there is different people look for the treatment. Heter, 1908, he found that the people or those celiac patients tolerate fat better than carbohydrate. But the Holland after that, he found actually even the carbohydrate is intolerance for those patients. Then has come, and he came with the idea with the banana diet, which is mean giving some carbohydrate, but excluding the damaged cereal. All this actually just walking around the real problem till the real issues discovered by Wim Dick from Netherlands in 1950. He was working there in the hospital, actually looking after the patient, and he was doing his doctorate actually. So he in the lab working with Widgers and Van de Kamer. He started to notice, because it was a poor area and every patient admitted to the hospital, they give them a simple food. So every time the food is different. So what they noticed, that the stool fat gets more and more when they give the patient wheat. And that was the lead for discovering the wheat, barley, oats, and rye as a cause for this disease. It actually was observational from him, but later on he started to examine different kinds of cereal, and he actually discovered that this is the problem. So that is when the people discover the treatment, which is avoiding this disease. Then the issue came how to diagnose with the disease. They know it is the problem in the tummy, so the bowel, the absorption. So they were looking how to get samples. And the first one get samples is Polly, and he's a surgeon. During one of his surgery, he got samples and he found really there is phyllis from one of the patients, and he found there is a phyllis atrophy and infiltration. Then after that, the people came in 1955, Royer and his group from Argentina, and also the Chenner from England. They tried to do a section way to get samples and for diagnosis of celiac, till William Crosby came in 1957, who discovered this capsule, which is put it down with the knife inside the capsule. Look at under fluoroscopy, and once it is in the place, he tried to quick release of knife and give you a small single biopsy, which help a lot to diagnose this disease. Then after that, development of technology to improve the endoscopy to get more biopsies came. And if you see here the Cosmos gastroscopy, which was mainly rigid endoscopy going down, which is what at that time was having, as you know, the risk of perforation every time they go down. So they start to think about making it more safe. At that time, they discovered that putting a rubber at the end and make it more flexible on 1911 by Elsenzer gastroscopy, they call it. Then later, this man, Wolf Schneider from German, who worked with his wife, that's his wife, which is, she was working as a nurse. He discovered that a scope, which is the real scopes, looks like our scopes. He make it more flexible at the end and going easier. Then after that, the development of endoscopies goes through different doctors, different modality, till we get what we have these days. Also during these times, in another part of laboratory, we're working for discovering way to discover this disease. So the antibody against gluten in 1958 was there, but was not specific, not sensitive. Then the antibody against reticulin in 1971, again, not specific, not sensitive. Till 1983, when they discovered the anti-endomysium antibodies. But the problem, because it comes usually from the esophagus of monkeys, so that was very difficult, so very expensive, so it wasn't available easy for everybody, so it wasn't the real helpful. Till 1997, when they discovered the tissue transplant glucomanase antibodies. And that time, 1997, when I go through my slides later on, just remember this date, because this date, the time, changed everything, changed the incidence and the prevalence of the disease all over the world. So that is summarizing the history regarding the celiac disease from the beginning. Again, the Eritreus, he's the discovering the disease, and the Guy, he is the one really describe it for the modern medicine, and Dick, he's the one discovered the treatment. So if we talk about celiac disease, we always should remember two things they blame for developing celiac disease. The first one is the wheat consumption, and the second one is the genotyping or HLA DQ2, DQ8, where they found those two factors very important to develop celiac. Then in this map, you can see the level of wheat consumption. If you see the big red ball, it's mainly in Europe and in our area in Middle East. So actually we are one of the most people consuming wheat, plus other area. You can see Australia, Argentina, and North America. Also, another map regarding the frequency of DQ2, you can see the DQ2, which is the major actually genotype found in celiac disease. It is also concentrating more in Europe and in the Middle East, but still you can see it in other countries. The last one, which is DQ8, you can see it less frequent than the DQ8, as all paper explain that. But again, it's still with the Europe and the North Africa, it's having a higher number. This is just example for the DQ2 and the Q8. If you remember, if you see the Sahrawi area carrying almost 23% of them DQ2, but if you see in Mexico, actually almost zero. I cannot believe zero, but almost zero, we'll say. But most of them, they carry DQ8, 28. So that may explain why in Mexico also they have a high number of celiac disease. And in other countries, as you see here in USA, they are almost 13% DQ2. So more of DQ2. And here there is correlation between the wheat consumption and the frequency of HLA DQ2, DQ8. Really, we cannot explain why, but once the wheat consumption is bigger or higher, you will find those people or population carrying more of HLA DQ2 or DQ8. Once the wheat consumption is less, then you find most of those people, they don't carry HLA DQ2 or DQ8. Why? It's not clear why, but that was observed. And also these two were linked with development of celiac disease. So if we go over the map, the world map, you see that the celiac disease was proven diagnosis in Europe in 0.8%, by serology was 1.3. In North America, 0.5 proven, and in Australia, 0.5 proven. And if we concentrate on these three, because this is the developed country, that is the risk. Most of them, they go back to Europe originally. But if you look in North America to the Indian people or American Indian, they have a higher prevalence actually than the other population in America. If you see the South America, you will see there is a big variation between 0.3 to initially, but the serology 1.3. Here in the South America or Africa or Asia, there is a lot of things make you in doubt about the numbers because of the data, but because there is a lot of research and a lot of data like Europe and America, but still consider less frequent than Europe or America or Middle East. So that is the worldwide prevalence of the disease. And here is summarize it. And as you see, that for me, I think the more important is the yellow one, which is proven by biopsies. The green indicates is serology. But don't forget, some countries, they just go forward the serology. Some of them, they do just the TTG, then the second one, endomysial. If both positive, they consider it, just because of the lack of facilities and the way of proper diagnosis. And even in different studies here, you see is 96 studies, different country from different people. If you see the number regarding serology only, we are talking about between 1 to 2. It goes up to 3. So most of the studies indicate the prevalence is really something between 1 and 3 regarding the serology. And regarding the proven by biopsy, most of the studies talking between 0.5 and 1%. So that is the general or global prevalence of celiac disease, which is, they consider it nowadays as 1%. If we take it by continents, then we see in the Europe, or in North America there, and Canadian, USA and Canada, they are almost the same. They are around 0.75%. But look to Europe. Europe also the same range, but there is difference between the countries. The highest one in Sweden and Finland, actually, they carry 3% and 2% prevalence of celiac disease. While in German, it's only 0.2%. And the big question, why? They consume the same amount of wheat. They have the same actually frequency of HLA DQ2 and DQ8. And in spite of that, German, it's much, much less, which indicates there is other factor than the wheat consumption or the gene susceptibility actually. So which need to be looked up. Other countries, they are ranging between this number. If we go through Australia and New Zealand, they carry 1%. And as I mentioned, they are almost the same risk like the North America. Regarding the South America, most of the studies done actually in Brazil and Argentina. We don't have enough data from other countries. In Brazil, the proven one is 0.3%, which I think that goes because they also lack of some facilities. Because if you look to the serology one, it goes to 1.3. So there is a big difference. So maybe they don't go and scope all of those patients, which lead to this minimum number in Brazil. The Argentina is 0.6% and the Mexico is 2.7%, but this one is serology. Mexico, they depend most of the time on serology. Regarding Africa, and there's another important interested things in Africa is the Sahrawi. The Sahrawi, or those Arab from Berber, they are coming from Sahrawi area here, or even from the south of Algeria. They have the highest incidence or prevalence of celiac disease, 5.6. Not only that, they have the most severe phenotype of celiac disease. So most of them, they present with severe diarrhea, severe failure to thrive, with a high mortality rate other than or rather than other countries. Why? Again, it's not clear. So there is something else playing role here for those people. Regarding other countries, they carry almost the same range, which we mentioned it between 0.5 to 1. So Tunisia here 0.6, the Libya it's 0.8, Egypt 0.5%. But have a look here. all the celiac disease in Africa, you can see it mainly in the North Africa, while sub-Sahara here, they don't have a lot. Yes, they don't do a lot of investigation because of their financial situation. But even if there is some studies like here in Burkina Faso, it tend to be zero. There was no celiac disease. They looked for celiac patient and they in one group, and it was zero. In South Africa, there is only case reported. They report only 20 patients to have a celiac disease. In Sudan, only 8 patients. In Djibouti, 7 patients, sorry. In Djibouti, it's only 8%. So even though they don't have, it is still under diagnosed, yes, but it's still considered as just a case reported there. So that is regarding the Africa. If you see regarding the DQ2 here, which is important, Sahrawi, Libya. So here I'm talking about North Africa. They are carrying DQ2 more than those on the South Africa. Plus, when you go back to the wheat consumptions, those in the North area consume more wheat than those in the South area. We know that the South area is the poor countries, so they don't have a lot of food. So at the end, they don't consume a lot of wheat, but they don't have a lot of celiac. We'll concentrate more on our continent, which is the Asia. So if you see the Asia, the wheat supply for Asia, in our area here, you see Turkey, Jordan, and Iran, and Saudi Arabia, we are almost between 300 to 400 grams per person per day. The Central Asia also, which include Kazakhstan and Uzbekistan, they are the same. But once you go to the east or south, this consumption of wheat is less and less. If you see it in China, it starts to decrease to 173. And if you see like here in North Korea, it's just 59, and South Korea is 139. If you go to the south area, you see in the Philippines is just 63 grams per person per day, Vietnam just 29, Thailand is 30. So they don't consume a lot of wheat. Actually, as we know, the stable diet there is actually the rice. So even their cereals is depend mainly on rice. So that is regarding the Asia and the wheat consumption there. If you look up to the DQ frequency in Asia, and we concentrate on the major one, which is DQ2 here, you see it's more frequent in our area, again, in the Middle East, in Turkey, in Lebanon, in Israel, in Iran, in Saudi Arabia. All they have higher one than those in the South Asia. Just see the Philippines, the frequency of DQ2 is just 4. And in Thailand is 6 to 13. In the South Korea is 0 to 10. So they have a less wheat consumption, they have less frequency or distribution of DQ2. With this one, if we link that with what I mentioned before, so we are expecting how to distribute the celiac in Asia. And if you see in Asia, Turkey, the prevalence is 0.5%, while in Lebanon is Lebanon 0.5 also, Israel 0.6, Iran 0.8, and Russia. However, Russia, we don't have a lot of data. There is deficient data, but in general, they mention 0.5%. In China, it's very difficult because, as you see, it's a big country. So it's different from place to place. If you see the north area, it goes up to 0.7. But if you go down to the south area, some reported it's even they don't report it. They don't have a celiac disease. And if you look into Japan is just 0.005. So they don't see a lot of celiac. They don't have a celiac. Vietnam, they have study there done and they did the TTG and was positive initially. When they did the endoscopy, it turned to be 0. There was no patient in Vietnam actually reported. So it is very minimum, and even if there is, I mean, it looks even absent in some area. If we take a model for the celiac disease, then the best model will be the India. They have a good research. They are doing good effort there. In the North India, the wheat consumption is high. So the celiac disease is 1.23%. When you go to the east part of India, it goes down to 0.87, and the wheat consumption goes down. When you go to the south of India, where they don't really, the main things also rise, the prevalence goes down to 0.1%. So there is a link, it looks like, between weight consumption and the distribution of celiac worldwide. Regarding Saudi Arabia, Dr. Abdurrahman is coming, but it's really sad to see this number, 1.5, and maybe Dr. Abdurrahman will clarify that's more. So we are one of the highest, actually. If you see here, for the HLA DQ2 for India, there was no big difference between the north and the south. So the main difference was the wheat intake in India. So that is regarding prevalence in all over the world. The other things regarding the incidence, which is it is increased by very clearly. So if we are talking here, or I will talk about it in per 100,000 person per year, they notice is the number increase, and the incidence is the range almost 7.5%, which is really high. In the USA, between 50 and 2010, it is 8.1%. If you see in the UK, the pediatric incidence is 12.8% between 90 and 16. In Wales and UK in adults, it's 11.3. In Sweden, in pediatric incidence, and this is very important, from 1998 to 2003, the incidence was 21.9. But since 2003 till now, it goes back and is stable. It became just 3.1%. And this is the trend between, you see here in different countries. You hear from Denmark, from UK, from Netherlands, from Germany, Italy, different countries. And you see the celiac initially in 60s, 70s, it was not really, the incidence per year was not really high. So we are talking most of them below 5. The increase actually started here. And if you remember here, what happened? I mentioned that the discovery of the TTG, 1997. When the people start to have a facility to diagnose it easier, then they start to discover more and more, and goes up to more than 20s in some countries in 2010. And again, this is explained before 2000 and after 2000. Before 2000, the incidence per year was very high, above 12.7, just in Finland, Sweden, and Norway. That's the area considered to be high with the celiac disease. But after discovering the TTG and more awareness about the disease, it became most of the developed countries in the red area, which is more than 12.7. So that's another things happen. So why? Serology, it's very clear, it's make very big difference. Guidelines also it's make difference, updating guidelines, make it more accessible, always. Like guidelines in 2016, the East began, which start to support the diagnosis sometimes without biopsy. In the southeast of Scotland, they diagnose almost 56% of their patients just without biopsies. So most of the patient diagnosed at that year in Scotland was without even biopsy. So that's you expect more and more patient to diagnose as celiac. However, I'm still worried about that point. Other things, the recognition of celiac disease. We know it for long times as diarrhea, failure to thrive, abdominal extension. But nowadays, we start to know another non-classical symptoms. So most of the patients we see in the clinic, they don't have the typical symptoms. We rarely see that. Most of them, they are screened or they have non-classical symptoms like short stature or iron deficiency anemia refractory to treatment. And also the screening strategy for high-risk group. All this lead to increase in the incidence and worldwide. However, the female-male ratio almost the same. Still, if you see the female here, it is giving you the 17.4 and the male 7.8. So female-male incident rate ratio is 2.1. More in children, so diagnosed more in children, so 21 in children in the childhood and 12 in the adulthood. And again, the incidence rate or ratio rate is 1.7. And this is expected. So that is what happened. To conclude my talk, celiac disease is still underdiagnosed. And as maybe you heard many times, the iceberg is still, we see the top of it. There is a lot of it is still below the sea. So especially the developing country, in the developed country like Finland, they went to the maximum, but now they are down again to the stabilized incident rate, which is almost 3.1. And Sweden, the only two countries, Finland and Sweden, stabilize the incidence rates, which mean they are now in the expected one, while the other, they are expecting more of increasing in the incidence because a lot of cases were not diagnosed before or missed before. Still, we have a deficient data, especially from developing countries. Celiac disease distribution is correlates very clearly to wheat consumption and genetic susceptibility, but there is another factors making difference. And the examples of that, German and the Sahrawi area. So, and the last question, are we in the Gulf countries one of the highest risk population for celiac? Thank you.
Thank you very much, Khalid, for your awesome presentation and great talk about this review for all epidemiological data for the last 10 years in the whole world. Thank you very much, Khalid. The floor is open for any questions. I think you have Q&A on the right corner of the Zoom. You can just post your question and we can ask the speaker to answer it. So I have one question, Khalid, about the consumption of wheat. Do you think that preventing the kids from eating wheat in early ages, is there any published studies about that it may prevent from celiac?
I don't think they will go to that point. The point is decreasing or delaying the introduction of gluten. There is studies regarding the introduction of gluten. They didn't find a real evidence support to go for that, but still that's what they are looking for. But preventing gluten, it will be something difficult because you will open for another disease. That's definitely.
You know, we are from Al Khobar now. I think this is from people living in beaches area.
Yeah.
In your review, is the beaches area close to the oceans had less celiac than the cities which is away from oceans and seas?
Okay, so that is depend on their foods. So I don't think so. No, it is not regarding the area actually. It's regarding the traditional foods that people they consume. So if you see in the South Asia or the East Asia, they are eating mainly rice, even their cereal, and then so they are not really obsessed regarding gluten like us. But so that's what make different, but not the area itself or the climate or no.
Sure. So
unless you don't eat gluten.
Yeah. Sorry, Khalid, we have more than 1,120 audience, right? And there is so much question, but I will conclude by the last question, Khalid, if you allow me.
Sure.
Last question is about your data about the kids as well adult. So do you think that celiac is disease of all ages? It can affect adult as well children? This is the last question.
Yes, the only difference is that usually diagnosed earlier, and they supposed to be diagnosed earlier. That's the only difference, but it's affect any age actually.
Well, great talk, Khalid. Thank you very much for your time. Thank you for the audience for their question as well. And I would like to thank you, Khalid, again, and enjoying the rest of the day. Dear ladies and gentlemen, I'm moving now to the second speaker. Second speaker will be talking about very interesting talk to all of us in Saudi Arabia as well, Gulf area. He will talk about celiac disease in Saudi Arabia. Please welcome one of the senior researchers in the kingdom, Abdulrahman Al-Husseini. He's the chairman of the Pediatric Gastroenterology Department at KFMC MOH. Abdulrahman, please join us, and thank you for your sharing with us your research and your knowledge.
السلام عليكم ورحمة الله وبركاته. مساكم الله بالخير جميعا. الحمد لله رب العالمين والصلاة والسلام على نبينا محمد صلى الله عليه وسلم. Thank you, Dr. Maher, for your kind invitation. It's really my pleasure to present this important topic among this audience, huge audience actually, and I think they are mainly pediatricians or GPs, so I hope it will satisfy them. When Dr. Maher asked me to talk about this topic, it was really, I stayed like few days just thinking how could I approach this important topic, should I talk about it? Especially Dr. Khalid will talk about like celiac disease worldwide. So I thought that it will be better for me if I review the literature, the local literature, and find those studies published and present them to you. So this is what I have done. So last week I have done PubMed search, and I found around 42 publications from Saudi Arabia, and I have divided them among into several groups, like several groups, like 12 papers published about clinical pattern, and screening high-risk groups, 12 papers published, and 4 papers reported about screening the general population, and 4 papers published on the genetic susceptibility, and 3 papers talked about the correlation between celiac serology titers and enteropathy, and only a single paper talked about the pathogenesis, and 6 more papers talked about other subjects in celiac disease, like about quality of life and awareness, as well as use of social media. So I hope I did not miss any paper through my search, and apologize if it happened. So let's go now through this journey. In the paper that published about the clinical pattern of celiac disease in Saudi Arabia, there are several papers. One of the main 2 papers actually was from Dr. Asad and Dr. Umar Saada. They published about 62 and 39 cases of celiac case series of celiac disease. The age at presentation around 4.7 and 9.6. The clinical presentation is important to note here that most of the patients presented with classical presentation of chronic diarrhea, abdominal distension, and failure to thrive. But important to notice that the study cohort in those two papers are a little bit old. Like for example, Dr. Saad, it was from late 90s and early 2000. And Dr. Asad mostly from late 1990s, and Dr. Saada from early 2000. So that's probably, I could think, why most of the patients presented with classical presentation. Another follow-up paper from also the group of Dr. Asad in King Khalid University Hospital reported on 59 children with confirmed celiac disease. I have underlined some important findings here. The median age, as you can see here, is 80 years. It was in the previous study from Dr. Asad, it was 4.5. Another important finding is that now the critical disease in this more recent study cohort is much less. It's only constitute like 30% of the study cohort, and the remaining were either non-classical presentation or belong to high-risk groups. And I think the difference in our practice, like screening more high-risk groups, and also the pattern, the referral pattern in Saudi Arabia has changed, that we are identifying more cases now of celiac disease, and that's why we are seeing less cases of classical presentation. Also, the papers on clinical pattern of celiac disease reported on short stature, and this is a report from also Dr. Asad. He reported a prevalence of 11% of celiac disease among short children. Another study also from Dr. Saada reported, he retrospectively studied 351 patients with isolated short stature and growth hormone deficiency diagnosed during the period of 2002 to 2016. And patients with positive tissue TTG antibody underwent endoscopy. He found 4% with celiac disease, and 4% among 350 with growth hormone deficiency. So the important finding from this study is that the growth hormone deficiency in a short child should not preclude the search for celiac disease, and the growth hormone deficiency potentially improve on gluten-free diet in the majority of cases. So if you have a child who has short stature and growth hormone deficiency, and I think it's, according to this study, I think it is valid to screen for celiac disease. Another paper from Jeddah, Dr. Rassan Sukkar, also reported on the growth impairment in celiac disease cases, and he reported around half of the patients had underweight at presentation. But important finding is that still celiac disease can be diagnosed in patients with normal weight and even in obese patients. Here I will talk about extraintestinal manifestations of celiac disease. Another study from the group of Dr. Asad in KKUH also reported on rickets as presenting finding for celiac disease. And here the diagnosis of biopsy confirmed celiac disease was confirmed in almost 40% of patients with rickets. So the message from this study is that patients with rickets, that is refractory to vitamin D supplementation and calcium supplementation, should be investigated for celiac disease. This is another study talk about the negative impact of celiac disease on bone. This is on adults from Mona Foda from King Khalid University Hospital in the Endocrinology department. She investigated children and adults actually, and collected laboratory results like bone profile, vitamin D, and parathyroid hormone, and imaging DEXA study, and defined osteoporosis as a Z-score of lumbar spine and femoral neck of less than minus 2.5, and defined osteopenia as a Z-score of less than or equal -1, but and above minus 2.5. And find that DICSA was ordered only in 7% of children and 36% of adults. Vitamin D deficiency was prevalent and significantly higher in adults as compared to children, and low bone mass density in adults was very common. So the message from this study is that it's very important to investigate for osteopenia and bone disease in newly diagnosed celiac case, and to supply adequate amount of vitamin D and calcium. Also, celiac disease has a negative impact on teeth, as shown here by a study from Dr. Umar Saada from Jeddah. He investigated in a case control study of 208 participants, and compared to 104 children with celiac compared to 104 healthy controls. And the result is that celiac disease patient has significantly higher prevalence of delayed dental maturity than controls. We should not forget that celiac disease is not limited to the small intestine. However, it is a multisystemic disease that can involve other organs, and as demonstrated here in this case, this is an adult who presented with new onset seizure disorder that was unexpectedly found to have bilateral occipital calcification and high titer of TTG-IgA. Another organ involved could be the liver, and this is a case reported from our group in King Fahd Medical City. This is 11-year-old child who presented with cirrhosis, end-stage liver disease, splenomegaly, and severe ascites. And extensive investigations was negative, and then we investigated for celiac disease and showed very high TTG-IgA and confirmed by intestinal biopsy to have celiac disease. The liver failure here reversed on gluten-free diet, but cirrhosis persisted. So another message is that when you have a child with unexplained liver disease, whether it's elevated liver enzymes or even end-stage liver disease, you should screen for celiac disease. Now, second, I'll talk about screening high-risk groups. This is celiac iceberg. I like to present it. The tip of the iceberg, in any country, the celiac iceberg consists of two parts. The tip of the iceberg, waterline, which is visible to us, and this is represented by symptomatic celiac disease. And the papers that I just have mentioned in the previous slides are typical examples of the tip of the iceberg. However, the major part of the celiac iceberg is below the waterline, so it is not visible to us. And it consists of either silent celiac disease or potential celiac disease. And the difference between silent celiac disease and potential celiac disease is that for potential celiac disease, they have positive serology, but negative mucosal changes. However, in silent celiac disease, both serology as well as biopsies are abnormal. However, in silent celiac disease, the patient is asymptomatic. The question here is how to diagnose this part, which is the major part, the under the waterline. There are two methods to make a diagnosis of these cases, either to screen for high-risk groups or to do mass screening of general population. Why is it is important to make early diagnosis of celiac disease? If celiac disease, if untreated, can cause significant morbidity and mortality. It can cause anemia, malabsorption with growth impairment, liver disease, neuropsychiatric disturbance, low bone disease, infertility, delayed puberty, dental problems, autoimmune diseases, and even late complications like malignancy and osteoporosis, and even more complications. And all these consequences are a significant burden economically as well as medically on any health system. Here I will summarize to you the studies published locally to investigate the prevalence of celiac disease among type 1 diabetic patients. The red bars indicate studies that investigated both children, adolescents, and adults, while the remaining are only pediatric. The last two studies are serology-based celiac disease. So as you can see here, there is a wide range. However, in most of the cases, it ranges between 5 and 12%. Apart from just a single study from Jeddah reported a prevalence rate of 20%. As compared to other countries, as you can see on this slide, I mean, it's very wide spectrum. It ranges between 2% in Brazil to almost 16% in Argentina. And as you can see here, I made the average of prevalence rate in Saudi Arabia around 10%, which is still considered among the highest ranking rate of celiac disease among diabetics. Another high-risk group is Down syndrome patients, and there are two studies, one by Dr. Saada and one by Dr. Ruwaili from King Faisal Specialist Hospital, and they reported 2% as well and 2 and 10% prevalence rate of celiac disease among Down syndrome patients. Another group from King Faisal, from the rheumatology group in King Faisal Specialist Hospital, they try to investigate if the prevalence of celiac disease is high among SLE or rheumatoid arthritis, because those are two autoimmune diseases. So they have investigated 250 patients with SLE, rheumatoid arthritis, and juvenile idiopathic arthritis who had regular follow-up in the rheumatology clinic and were screened for celiac disease using anti-endomysial and anti-TTG antibodies. This table summarizes the findings. I just would like to draw your attention to important findings. The AGAA, this is anti-gliadin antibodies type IgA, and another autoantibody is the anti-gliadin IgG type. And as you can see, there is significant elevation of positive celiac markers in this cohort. However, when those antibodies, those patients underwent endoscopy and intestinal biopsies, the biopsies were normal. So those were false positive celiac markers. However, there are two patients in the rheumatoid arthritis group who had positive endomysial plus TTG IgA antibodies, and only two of this group underwent, confirmed to have celiac disease. So the message from this study, and also as the authors concluded, is that there is significant high rate of false positivity of celiac markers among this study cohort, and they recommended against routine screening of those patients for celiac disease. This is another study that screened. Irritable bowel syndrome is not one of the high-risk groups that we need to screen for. However, I think the findings from this study is very important. They investigated in a case control study design almost 500 adults with diagnosis of irritable bowel syndrome, and another controls of 482 healthy adults, and they screened both groups for celiac disease. So celiac disease was diagnosed in about 10% of the cases and 2% of the controls. So the message, I think, from the study is that there is significant overlap of GI symptoms between celiac disease and IBS, and it's important that to screen patients with IBS for celiac disease, because 10% prevalence rate is very similar to the prevalence rate of celiac disease among diabetics. So I think patients with unexplained GI symptoms need to be screened for celiac disease. Now we'll go over the papers that talked about or investigated the general population by screening. I will just introduce to this to my slides by talking about the significance and benefits of mass screening for celiac disease. One of the benefits for mass screening for celiac disease in any population is to estimate the magnitude of health problem in a society and to make an accurate statistic of any health problem to guide short and long-term health planning and distribution of medical resources, and also to increase awareness of public and physicians for the wide spectrum presentation of celiac disease. And also very important is that early detection and gluten-free diet of celiac disease can prevent significant morbidity associated with late diagnosis. There are 4 papers that try to screen the whole general population. The first paper was from Jeddah by Dr. Yasser Khayyat. He screened 204 individuals attending blood donation center, and he came with a figure of 1.5%. This is a serology, not biopsy confirmed. So the limitation here is very clear. It's very small sample size, and also it's not biopsy confirmed celiac disease. And then after that, Dr. Al-Jibreen from King Khalid University Hospital, he did this mass screening study. He investigated 1,167 adolescents from Al-Qasim, Medina, and Asir region. This was in 2007, 2008. And blood specimens were tested for endometrial antibody only, but no intestinal biopsies. So the results showed the prevalence rate of 2.1 in Asir, 1.8 in Medina, and 3.2 in Al-Qasim region. Again, here the limitations that there is no biopsies taken, so these figures are, are not accurate. Also, endometrial is very highly observer-dependent test and is not recommended to rely on for mass screening, and no details given on clinical symptoms or signs. And it is a relatively small sample size for mass screening. When you talk about mass screening of the general population, you talk about several thousand of population. And then a third study from the Eastern Province by Dr. Maher Al-Hatlani. He investigated 1,141 students attending 9 schools of military campus of National Guard in Al-Ahsa region and blood tested for IgA TTG type. And biopsy-proven celiac disease was confirmed in 1%, so it's like a prevalence of 1 case of celiac disease among 100 healthy Saudi children, and all cases were asymptomatic. Another mass screening study we have done by our group from King Fahd Medical City. We investigated almost near to 8,000 Saudi students aged 6 to 15 years of both gender attending intermediate and primary schools, about 104 schools using IgA TTG on a venous blood sample, and the celiac disease was diagnosed in 1.5%. So this translates into 1 in 66 Saudi children. I think by the end of this mass screening study, we have explored the celiac iceberg and answered some research questions. First question was, what is the clinical pattern of undiagnosed celiac cases? I mean the celiac iceberg that is under the waterline. And silent celiac disease was diagnosed in 37% of those 120 patients in our study. And mild symptomatic form with normal growth or even overweight or obesity in 48%. And GI symptoms and impaired growth was present in 15% of the celiac disease diagnosed on mass screening. Now let's talk about numbers, and we calculate or translate those figures, the prevalence rates, into numbers. Under clinical practice, and this was in 2014 and 15 when we have conducted this study. Celiac disease has been diagnosed in about 800 to 900 Saudi children less than 15 years of age in Riyadh, and I got this figure through personal communication with other colleagues in Riyadh. The total number of students in primary and intermediate schools in Riyadh City during the year of 1435, when the study was conducted, is almost 500,000 students. So prevalence rates of 1.5 in Riyadh will be translated into a total of 8,300 undiagnosed cases of celiac disease in Riyadh City alone. So that means that at least 90% of celiac disease in Riyadh City alone remain undiagnosed. And what we see in our clinic and in hospitals only represent 10% of this clinical load. What's the magnitude of the celiac disease as a health problem in general in Saudi Arabia? I mean, again, now I'm extending the statistics toward the whole Saudi Arabia, because it seems that the prevalence rate in Saudi Arabia seems to be between 1% and 2%. So total population in Saudi Arabia in 2014-15 was almost clear to 31 million. 67 of them are Saudis. 50% are below 20 years. So this is about 10 million. So prevalence rate of 1.5 in Saudi Arabia equal to a total of 155,000 undiagnosed cases of celiac disease in individuals less than 20 years of age. So this is a huge number and a really very significant load on our health system if not diagnosed early. Now let's move to the studies that talked about the genetic susceptibility. Before I talk about these studies, I would like to introduce those studies by talking about the HLA and its role in development of celiac disease, because I understand that most of the audience here are general pediatricians or GPs, so I thought it will be beneficial to them to know these facts. For an individual to develop celiac disease, there should be some what we call HLA DQ2 and or DQ8 molecules on the antigen presenting cells. These molecules are important to bind the gluten peptides and present them to the T helper cells to release the inflammatory cytokines that lead to total vellus atrophy. So this is in brief the role of HLA DQ molecules in the development of celiac disease. So imagine now with me, if a patient or an individual, if an individual does not carry HLA DQ or DQ2 or DQ8 molecules, that individual will not be able to bind the gluten peptide and so will not be able to present it to the T helper cells. So the result is that the development of celiac disease in that individual is almost unlikely. So that's important to know. Now let's talk about the papers that investigated the HLA DQ role in development of celiac disease. This is a paper also from our group in King Fahd Medical City, investigated 192 healthy children, those who tested TTG IgA negative during the mass screening study. So they were typed for DQA and DQP1 genes by the SSO probe method. This table summarizes the results. The high risk DQ molecules, and here indicated by the red as well as the orange boxes, they constitute around 39% at high risk, while the other molecules, DQ8, the homozygous, DQ2.2, and DQ2 2.2, the single dose, and others, they were either in the low risk or very low risk, so they constitute around 61%. Why I consider DQ homozygous and DQ 2.2 double dose in this study as low risk, because the findings from the follow-up studies that I'll talk about it showed us that DQ 2.2 and DQ8 are not really of high risk in Saudi population, similar to like in other populations. And we'll talk about it in few slides. Now this is just a comparison of HLA DQ in different countries, and Dr. Khalid beautifully showed this, and Saudi Arabia, I mean, I think ranked among the countries with high prevalence of these high-risk molecules, DQ2 and DQ8. While in Japan, as you can see in the far, in the right-hand side, it's almost only 1% of the population that carry the HLA-DQ risk. So just to make these numbers into the context, this green circle indicates the total population of Saudi Arabia. 39% of this population carry the high risk, HLA-DQ 2.5 and DQ8, and only 1.5% of the whole population develop celiac disease. So the questions remain, as Dr. Khalid explained in his lecture. It remains that there are other factors playing a role here. Of course, wheat consumption is very important, but I think still, I mean, you know, most of the Saudi population, they consume wheat, but only 1.5% develop celiac disease. So I think it remains to be identified some other probably environmental or genetic factors. Another study, this is another study we have also published, and the aim of this study was to compare the HLA-DQ molecules among celiacs as compared to healthy controls. Again, we have typed them for DQ8, DQA, and DQB genes using the sequence-specific oligonucleotide probe method. And this table summarizes the finding. I will just take you through the most important findings here. We had 101 celiac patients in this group. It's very important to notice that none of them lack the high-risk DQ molecules. So, and this is the beauty of the HLA-DQ typing testing, is that if it is negative, then make that case unlikely to develop celiac disease. Now let's go to the most important findings of the study. Here, the aim of the study, when we have done it, is to compare or to know which of these molecules is of high risk as compared to the control. And our study indicated that the DQ 2.5 plus DQ8, so combined two molecules, they carry very high risk to develop celiac disease. They have odds ratio of almost 47. And this is followed by another high risk group, is DQ 2.5, the double dose, or we call it homozygous. And the DQ 2.5 and DQ 2.2, those two groups, they have high risk to develop celiac disease with odds ratio of 4 and 5. And this is followed by an intermediate risk group, and this is represented by DQ 2.5 single dose and DQ and combination of DQ8 and DQ 2.2. And those represent like only 1.6 odds ratio. And this is followed by other low risk group, as I said, you know, DQ 2.2 double dose or even single dose, or even DQ8 homozygous or double dose. They have low risk. As you can see, when you compare the homozygous, for example, DQ8, between the celiac group and the control group, there is no significant difference between the control and the cases. That's why I put here the DQ8 and DQ 2.2 molecules among the low risk. And this is and then it's followed by the very low risk, when there is either neither risk alleles, or there is only half heterodimer, either DQ2 or DQ05. And as you can see here, there is a risk gradient going from the combination of DQ 2.5 and DQ8 to going down. And this finding is very important actually to know. You know, in other countries, they have different high risk groups. So in our country, it's important to know those high risk DQ molecules, because by knowing this, you can counsel the parents. You can predict the risk of disease, especially among siblings of the index case. As you know, celiac disease can occur sporadically or can occur in families, in clusters. And HLA-DQ only explain about 40 to 50% of the heritability of celiac disease, and the remaining still remain really a puzzle. So Dr. Umar Saad and his group in Jeddah, they try to investigate if there is a potential non-HLA gene candidates in families with cluster of celiac disease. So they studied a Saudi family with 2 celiac disease affected siblings to discover the causal genetic defect using the whole exome sequence. And they identified that both siblings have inherited an extremely rare and deleterious genetic variant, segregating as autosomal recessive mutation, suggesting its putative causal role in the celiac disease development. Also, the same group, also in a different family, they did WES, and they identified another rare homozygous insertion deletion mutation in the conserved coding region of AK5 gene that showed classical autosomal recessive model segregation in this family. So those 2 studies that identified non-HLA genes are really promising and could explain some of the can explain some of the cases that occur that make some some families susceptible to develop disease as compared to other families. So now let's move to another area or topic that has been investigated locally by researchers in Saudi Arabia, and this is the correlation between the celiac serology titers and enteropathy. This is a study from our group in King Khan Medical City. Here we aim to evaluate the diagnostic performance of the DGP antibodies compared with TTG IgA to evaluate also to evaluate the correlation between DGP antibody titers and degree of enteropathy. And DGP, I mean here for the genetic pediatricians, I mean this is deamidated gliadin peptide. It's not the traditional one, the anti-gliadin antibodies. No, this is a more recent one. It's more sensitive and specific. It's called deamidated gliadin peptide. So we included children who underwent endoscopy and biopsies because of positivity of any of the serology tests in the celiac profile, either TTG IgA, DGP IgA, or DGP IgG type from 2012 to 2019. The result, as shown here, this graph, this is called ROC analysis curve. It shows that, as you can see, the blue line indicates the TTG IgA test, and the orange one indicates the DGP IgG type. It shows that the performance of these 2 tests are comparable to each other, and they are much better than the DGP IgA. In another graph, in box plotter graph, also we demonstrate here, this is for the titers of DGP IgG antibodies. It shows that the higher the titers of DGP IgG, the more severe is the intestinal disease, whether this is in symptomatic group or even in asymptomatic group, including those diabetic patients. Another box plotter graph, it shows that the TTG IgA in asymptomatic diabetic group, also it showed significant correlation between the level of the titer as well as the severity of the intestinal damage. So in conclusion from this study, similar to other ethnicities, DGP IgG assay among Saudis did not add, although it is comparable to TTG IgA, but did not add to the performance of TTG IgA test. And DGP IgG titer correlated with enteropathy. Diagnosis of celiac disease can be made in asymptomatic diabetic children with TTG IgA titer more than 10 times upper limit of normal with positive endomysial antibodies without need for biopsies. Another study also from our group in King Fahd Medical City. Here we evaluated the correlation between TTG IgA titer and degree of enteropathy, and also to evaluate whether the no biopsy criteria to diagnose celiac disease in symptomatic patients, as proposed by the SPGAN group, could be extended to asymptomatic celiac disease patients diagnosed during mass screening studies. So here the 93 biopsy confirmed celiac disease patients diagnosed during the mass screening study constituted the study cohort of the present study. Here the TTG IgA titers and endomysial antibodies at the time of biopsy and grade of enteropathy were assessed. And as you can see in this graph, there is significant correlation between the level of the antibodies of TTG IgA titers as compared to the correlation to the degree of intestinal damage. 34 patients of those 90 patients with celiac disease had anti-TTG IgA titer of more than 10 upper limit of normal. So this is like 36 of our study cohort. All of them had villus atrophy with positive endomysial and DQ molecules. The sensitivity and specificity of the anti-TTG IgA titer of more than 10 times the upper limit of normal in correctly diagnosed celiac disease was 100%. So in conclusion, from this study, we provide evidence that the TTG IgA titer more than 10 times upper limit of normal correlates with villus atrophy in celiac disease patients detected by mass screening. And this is a study from adults. This is the Dr. Ibrahim Al-Harbi from National Guard in Riyadh. They tried to, as you know, the adults, by the way, they don't recommend yet avoiding biopsies. They still do biopsies, whatever is the titer of the TTG IgA. In this study, they evaluated the correlation between the TTG IgA titer and degree of enteropathy in 134 adult celiac patients. The conclusion is that positive TTG antibody test can be applied for diagnosis of celiac disease without biopsy, particularly in symptomatic patients along with high titer, that is 5 to 10 times upper limit of normal, as shown here on the graph. So, talking about the pathogenesis, there is only one single study that tried to investigate the pathogenesis of celiac disease, and this study is from Dr. Mozan, recently published, and his group. I was honored to join him for this study. The objective of this study was to describe the gut fungal profiles in a cohort of children with new onset celiac disease. We collected the mucosal as well as fecal samples from children with celiac disease and controls, and subjected to metagenomics analysis of fungal microbiota communities. And we found that a higher abundance of some fungi and lower abundance of other fungi in children with celiac disease than in control children indicates fungal dysbiosis, suggesting a possible role in pathogenesis of celiac disease. However, as you know, this is like a cross-sectional study, so the association here does not imply causality, and I think it's very important to perform a much larger prospective controlled and even longitudinal studies to confirm those findings. And still other studies investigating the role of bacteria and viruses also are underway. Inshallah, we'll show the light, inshallah, recently. To finish, we'll talk about just a few studies that talk about other issues of celiac disease in Saudi Arabia. The issue of adherence, it has been investigated by Dr. Al-Sarfi from King Khalid University Hospital, and he showed that 60% of the involved children were reported to be strictly adherent to gluten-free diet. However, this, although it's a good percentage, 60%, but it is much lower than percentages reported from other countries. For example, in Canada is about 95, in Italy it's 87. So still, I think a lot of things need to be done to, encourage children in our community to comply on gluten-free diet. Also, Dr. Safi, he investigated the use of, or the effect, the impact of socioeconomic of gluten-free diet. And the result of his study showed that 100 of the participating families reported that gluten-free diet was not easily available in their areas. 17% of them reported that it was not available in other areas. 106, like about 94%, reported that the price of gluten-free diet was very expensive. 62% of the families reported that the diet was heavily affecting their family budget, and significant social difficulties were reported among the participating families and their children, including interference with the child's interaction with other children, the family's ability to attend social gathering, and also the family's ability to eat in restaurants, and even the family's ability to travel. Another study about the quality of life, this has been done in Jeddah by group of Dr. Amr Saad also in Jeddah. This is a case control study, included 111 Saudi patients with celiac disease. And this study showed that that the quality of life for Saudi celiac disease children on gluten-free diet is generally comparable to the healthy control, with the exception of the general health domain. And they reported that adherence to the gluten-free diet improves the generic quality of life domains. Another quality of life study from Dr. Samia Al-Freih has been also published recently. She has investigated quality of life among 73 children. And as you can see, as Dr. Umar Saada reported, in general, they have good quality of life comparable to the non-celiac patients. However, still 16% here, they reported poor quality of life. And important finding from the study is that most of the emotional and psychosocial elements of quality of life were related to the difficulties in availability of gluten-free diet in daily life. Another important study that tests the knowledge of physicians about celiac disease. It has been done by Dr. Asad Asiri from KQH. In a cross-sectional survey of hospital-based medical staff in primary, secondary, and tertiary care, public and private hospitals in Riyadh, the conclusion from this study is that the knowledge of celiac disease is poor among significant number of physicians, including consultants, which can potentially lead to delays in diagnosis. So Dr. Asad recommended that educational programs to be implemented to increase awareness about celiac disease. And to finish with is a study from Dr. Sarki. This study, the social media usage pattern among celiac patients. And the majority, like 96% of the investigated cohort, reported using social media network for their disease management. And the main use of social media by those patients is to search for gluten-free diet stores, and also to search for information, to search for, also about the exchange experiences, and also for social support. So this was the shape of the data on celiac disease in Saudi population 2 decades ago. We were not aware of the prevalence of even the genetic susceptibility, what was the clinical pattern, or the change in pattern, what's the use or utility of serology titers, other environmental factors. I think nowadays we are much better. We have better data on prevalence of celiac disease in different regions in Saudi Arabia. We know the genetic susceptibility of celiac disease in our population. Also, we know the change in clinical pattern, and we know the celiac iceberg. And also, we know the use of these serology tests and how good they are in correlating with enteropathy. Still, I think many investigations are needed to explore the pathogenesis and other environmental factors. So, in conclusion, ladies and gentlemen, the clinically suspected cases of celiac disease account only for a minority of patients, and that the majority of celiac disease cases remain undiagnosed. Our data provide evidence of a high prevalence of celiac disease among Saudi children and characterize the nature of the celiac iceberg among Saudi population. The Saudi population, they have high HLA-DQ susceptibility to develop celiac disease, and celiac disease constitutes a significant health and economic burden. And I think for future mass screening studies for celiac disease in different regions of Saudi Arabia are urgently required to assess for regional variability of celiac disease prevalence and to identify regions of higher prevalence. And I think also a strategy for identification, for early identification of celiac disease is very important to be considered, either through a mass screening strategy, although this is probably difficult with the infrastructure that we have nowadays. However, I think it's very important to consider case finding strategy at this stage, which is focusing on screening the high-risk population. So more research is needed to investigate the non-HLA genes factors and more research is needed to define the role of environmental factors in development of celiac disease. Thank you very much.
Thank you, Abdulrahman, for this extensive review about the Saudi celiac disease. Because of the time, we will just make it short. There is two questions. Question number one about the HLA-DQ susceptibility in Saudi. Have you linked this to the race or the tribe of the patients?
No, we have not. We have not done it. You know, when you talk about race, and I consider all Saudis, like all Arab, as one race. So if you talk about regions, yes, I think it's very important. And that's why I have asked, you know, in my recommendations that other studies in other regions also to be done. Especially, I think in the southwestern region. I think you know, that area of the Kingdom of Saudi Arabia is an area with the high prevalence rate of celiac disease. We get a lot of referrals. Most of our patients, those who we detected here in Riyadh, a significant percentage are from the southwestern region. So I think I would really encourage our colleagues in the southwestern region to investigate HLA-DQ molecules and also to do a massive screening study in that region.
Sure. The last question is about the fungal found in abundance in the gut with a patient with celiac. The question is about, can you give us the names for these fungi?
I don't remember them really from, you know, from just top of my brain, but there are different taxes of bacteria that are either more or less abundant. I mean, it's not only just the, you know, the abundance. It's it could be either abundant or less abundant in celiac cases as compared to non-celiac. However, you know, the names are difficult to remember, and unless I show them, otherwise, actually, I didn't want to show them because they are difficult names. So I apologize for that.
Thank you, Dr. Abdulrahman, for your valuable information, participation in these sessions. Thank you, Abdulrahman, a lot. Dear gentlemen and ladies and gentlemen, we will stop now for the break for 10 minutes, and sharply we will start our second sessions at around 7:40. Thank you very much. Thank you, Abdulrahman.
Yeah.
Bismillah ar-Rahman ar-Rahim. Dear all audience, we'd like to start now the second sessions of today. It will be about the celiac disease. Is there a new treatment for celiac disease on the horizon? So as we hear today about the celiac disease, which is a chronic immune-mediated enteropathy triggered by gluten ingestion in the genetically predisposed subject. The immunology response to gluten cause many histological abnormalities that aided by a secondary vitamins nutritional malabsorption. Today, my talk about the disease, briefly, pathology, to understand new medication, symptoms, diagnosis, treatment, and finally the conclusion. I will start by the few facts and key number. If you go through the PubMed, as of today morning, there is 37,079 results of PubMed, which has the celiac disease name. More advanced, you can find that celiac in children account for 8,700 plus publication. Treatment account for 16,000 plus published articles. As we know, the risk factor is vary between 10 to 30%, and I will not go in details about these factors, already mentioned by my colleague last day. About the disease in affected individual, recent evidence suggests that gluten evoke a signaling cascade, which trigger an inflammatory reaction with cytokine release, resulting in additional intestinal mucosal barrier dysfunction for damage of tight junction protein, namely zonulin, so-called leaky gut syndrome. The increased intestinal permeability allow gluten peptides to reach the lamina propria via either a paracellular or intracellular route, thus aggravating the inflammation with systemic complication. Already, we have been listened this early afternoon about the prevalence. So it is 1.4% globally, and the pooled global prevalence with biopsy 1.7%. And we know that the prevalence was higher in female versus male, and the prevalence in children is more higher than adult. In conclusion, celiac disease is the disease of all countries, all race, and all ages. Now, we will go through the pathology of the celiac disease. So we have been listened to the concept of the pathology. We do have genetics factor interacting with intestinal mucosa plus minus environmental factors. Gluten is the main storage protein found in wheat, rye, and barley, and is important for dough formation. It is classified as either a high molecular weight glutamine subunit, low molecular weight, the S-poor prolamine, and S-rich prolamine, which include alpha, beta, and gamma gliadins. If we go through this cartoon, I can go through few elements that we will help in the diagnosis and in the treatment of the future celiac disease. Gluten peptide that are highly resistant to intestinal proteases reach the lamina propria, either by epithelial transcytosis or through increased epithelial time junction permeability. Cross-linking and particular deamidated the deamidation of the gluten peptide by the tissue transglutaminase TG2 create potent immunostimulatory epitopes that are presented via the HLA-DQ2 or the HLA-DQ8 on the antigen-presenting cells. Subsequently, CD4 T cells are activated, secreting mainly Th1 cytokine, such as interferon gamma, which induce the release and activation of MMPs by myofibroblast, finally resulting in mucosal remodeling and villus atrophy. Additionally, the Th2 cytokines are produced, driving the production of auto-antibodies to gluten and TG2. Other cytokines, such as interleukin-18, interferon alpha, or IL-21, seem to play the role in polarizing and maintaining the Th1 responses. Furthermore, interleukin-15 link the adaptive immune system as well. Now I will move to the second slide, which will show you few innate immune responses and few medications that can be used. So here, upon stimulation with gliadin peptides, epithelial cells, macrophages, and dendritic cells secrete interleukin-15, which in turn upregulate both the NKG2D receptor on the epithelial cells. That one will stimulate cytotoxic lymphocytes, which induce increase in the epithelial apoptosis and permeability, as illustrated on the left side of the cartoon. Furthermore, the NKG2C receptor in the middle on a subset of NK, the natural killer-like intraepithelial lymphocyte, is stimulated by its epithelial ligand HLA-E on epithelial cell, resulting in their proliferation and cytotoxicity. Gliadin, like a cereals, on the right up part of the corner, can also directly elicit innate immunity response in the macrophages and dendritic cells via the patterns recognition receptors, like the toll-like receptor, for or other cells. This drives maturation of these cells and secretion of inflammatory cytokines, namely interleukin-1 beta, which is illustrated in the right corner of this cartoon, interleukin-8, tumor necrosis factor alpha, as well MCP1, which can potentiate the adaptive immune response to gluten. Symptoms. We all know about the symptoms, and I will not go in details because it's beyond the spectrum of this talk. Diagnosis. We know that celiac mimic many gastrointestinal diseases, as illustrated by our colleague in the pathology sessions. Briefly, the serology is the crucial component of the detection and diagnosis of celiac disease, particularly tissue transglutaminase, IgA testing, as well less frequently the endomysial IgA testing through histological analysis of duodenal biopsy as well with Marsh classification. Counting of lymphocyte per high power field and morphometry is important for the diagnosis as well as for differential diagnosis. TG2 IgA at higher level, more than 10 times above normal with the symptoms of celiac plus the positive endomysial antibody may defer the need to do endoscopy. In patients with home CD is strongly suspected in the face of negative biopsies. TG2 IgA should be still performed in the future. Determination of HLA-DQ2, DQ8 has very limited role in the diagnosis of celiac disease. Its value is largely related to its negative predictive value to rule out celiac in patients when seronegative in the face of histological changes. In patients who didn't have serological confirmation at the time of the diagnosis, and in those patients with a historic diagnosis of celiac disease, especially as a very young children before the introduction of celiac-specific serology, like those below 2 years. Now we will move to the bulk of the talk about the treatment. To decrease the toxic effect of gluten in celiac disease, different strategies have been explored by means of various molecular biology, microbial, enzymatic, and finally, pharmaceutical approaches. 14 possible medication in the near future. I will go through all of them. Due to the squeezed slides, I will mention the references in the last slide. Number one, the celiac disease vaccine. We are all impressed about it. When the immunoSAN-T have been implemented, Nexavax2, which is a peptide-based epitope-specific gluten tolerizing agent, utilizing the principle of immunotherapy in a similar fashion to the desensitization strategy used for allergic condition. This continued on June 2019, almost 2 years ago. Why? Because of the non-protective effect of that vaccine. Second, endopeptidase enzymatic degradation of gluten, a medication called latiglutenase. In the past, it's called ALF-003. Is a combine of ALF-001, which is the endopeptidase enzyme, endopeptidase that is driven from the endosperm of the Sphingomonas capsulata, and it degrades the gluten protein and reduce the immunogenic potential of the gluten. In phase 2 clinical trial, this medication, latiglutenase, shown to attenuate the gluten-induced small intestinal mucosal injury in patients with celiac disease who underwent 6-week gluten challenge. Another phase 2 clinical trial with persistent symptoms show no improvement. Third, gluten sequestering polymers called BL7010, synthetic non-absorbable copolymer of styrene sulfate with hydroxyethyl beta-acrylate. This polymer is reported to have high affinity to alpha-gliadine peptide, the one I show it in the pathogenesis cartoon. It's proposed is to sequester intraluminal gliadin and prevent its breakdown into immunogenic peptide. Preclinical study in NODQ2 mouse found model showed that BL7010 was effective at preventing the gluten-induced reduction in villus to crypt ratio, intraepithelial lymphocytosis, as well alteration in the permeability. This clinical trial had been completed and the results are yet to be published. This is the number of the study. You can Google it through the USA clinicaltrial.gov USA with this number. While the concept of sequestering gluten before it reaches the small intestine is very attractive, we need more data to ensure the safety of this way. Number 4, probiotics, which work by downregulating the pro-inflammatory immune response in celiac disease. They use Bifidobacterium natrum, which was assessed in the treatment of celiac disease. Testing period between 3 weeks between the result of the serology and the biopsy. It was associated with improvement of the GI symptom based on the GI symptom rating scale compared with placebo. The final baseline TTG as well DGB antibody concentration ratio were lower in probiotic group. Intestine permeability, which can be easily measured by measuring urinary lactulose to mannitol fraction excretion ratio, was not affected by the treatment. Currently, there are no firm guidelines to recommend probiotic use in celiac disease. 5, tight junction modulator called larazotide acetate. Larazotide acetate, or AT1001, is a synthetic octapeptide whose sequence was derived from similarity to the zonuola, which is the tight junction protein, which is secreted from the Vibrio cholera. Larazotide acetate acts to improve tight junction integrity, preventing gliadin-induced permeability, and thereby reducing the small intestine inflammation. Several phases, number 1 as well phase 2 clinical trial involving the larazotide acetate have been completed. Recently completed phase 2 show that larazotide 0.5 milligram 3 times a day reduced the symptom of celiac patient on gluten-free diet better than gluten-free diet alone. The study represented a successful trial of larazotide as a novel therapeutic agent in patients with celiac disease who are symptomatic despite gluten-free diet. While these data are promising with regard to symptom improvement, lack of information on histological improvement is a drawback in these studies. Still, a lot coming. Number 6, HLA-DQ2 and DQ8 blockers. In susceptible individuals, especially when we hear from Dr. Husseini that we are common fragile to these two alleles, the deamidated gliadin peptide bind with a high affinity to DQ28 expressed on antigen-presenting cells, which in turn stimulate gliadin-specific T cells. The activation of gliadin-specific T helper 1 and 2 inflammatory pathway may have a self-perpetual role in ensuring the entry of additional gliadin peptide to the lamina propria through increased intestinal permeability and or through a CD71 SIGA gliadin complex transport mechanism. HLA-DQ2 8 lead to the preferential presentation of gliadin peptide to CD4 helper cell in the lamina propria, leading to induction of secretion of interferon gamma dominated inflammatory cytokines. DQ2-8 blocking peptide analog act by preventing immune activations. This novel therapy remain in the preclinical phase. TG2 inhibitor. TG2 inhibitor play a major role in the celiac pathogenesis via the deamidation and transamidation of gluten peptide, leading to an immune-based response characterized by inflammation in the small intestinal mucosa. Those inhibition of the TG2 may prevent the presentation of gluten peptides by HLA-DQ2 and 8. TG2 inhibitors proved to be protective against gliadin-induced toxic effect, an increase in the CD25 IL-15 positive cell Also, upregulation of T regulatory cells, as well crypt cell proliferation. A new medication called Z1227 is a drug that acts as a direct and specific inhibitor to 2G2 in patients with celiac disease. It has been already tested in clinical trial in phase 1 clinical trials and have been to be very safe in healthy children. A proof of concept study will enroll patients with celiac disease in clinical trial 2, aiming to show some protective effect of this new medication against TG2. It's a new drug, act as a direct specific inhibitor in patients with celiac disease, already tested, as I mentioned, and as well, we are waiting for the result of the stage or clinical trial phase 2. This is the registration number by USA clinicaltrial.gov.USA. Now, interesting, hookworm infection, Necator americanus. It is hypothesized that intestinal parasite infection help regulate the immune system and prevent autoimmune and allergy diseases. According to the hygiene hypothesis, the lack of early childhood exposure to intestinal parasite has created a predisposition to develop autoimmune disease in developed countries. Randomized, double-blind, placebo-controlled trial was conducted to study the effect of hookworm infection on gluten challenge in celiac disease. No statistical difference in the histological damage, as well induction of interferon gamma in the peripheral blood after the 5 days gluten challenge in a patient inoculated with the hookworm. The study results have not been published yet. Another study examined the influence of experimental hookworm infection in preventing intestinal damage and symptoms using escalating gluten challenge in celiac patients. 12 celiac disease patients on gluten-free diet were inoculated with N. americanus larva with a 52 weeks duration, were given escalating dose of gluten. Median villus height to crypt depth, which is very histopath phenomenon in celiac ratio, didn't decrease as predicted after the gluten challenge. Quality of life indices improved and the mean TTG IgA titer declined despite the escalating dose of gluten. Based on these findings, we believe that induction of infection with this hookworm can promote immune regulation with tolerance to gluten in celiac patients. Given the nature of this novel therapy, it is difficult to imagine the routine clinical use of N. americanus in the management of celiac disease. Number 9, nanoparticle. Well, the Temglaya, which is the core pharmaceutical Norfolk, is a nanoparticle-based investigational product which proposed to develop immune tolerance to gluten exposure through non-inflammatory antigen presentation. FDA recently granted what is called fast-track designation for the product, and phase 1 study is underway to characterize its safety and tolerability when either 1 or 2 IV doses are given to a subject with celiac disease. Again, in the bottom of this slide, NCT is the number of that clinical trial. 10, cathepsin S inhibitor. Cathepsin is a lysosomal cysteine protease that has a role in antigen presentation to the MHC class 2, as illustrated previously in the cartoon, in this first cartoon. R0545972 is an orally administered competitive inhibitor of the cathepsin S. A phase 1 randomized double-blind placebo-controlled multiple dose parallel study to investigate the pharmacokinetic, dynamics, safety, tolerability in a subject who is well controlled with celiac. The primary outcome of this study was measured by the number of participants who respond to gluten challenge. The study is completed. Up to this moment, we are waiting for the publication of the results. 11, immune cell targeted therapies. This is one of my preferred topics to talk. It is one of the future coming. IL-15, which is the cytokine that regulates the activation and proliferation of T lymphocytes and NK cells. IL-15 overexpression lead to increase in the number of intraepithelial lymphocytes, a characteristics finding in seed. Tofacitinib is a pan-JAK inhibitor that block IL-15 signaling. It has been approved by the FDA for the treatment of rheumatoid arthritis. Tofacitinib has been effective in the transgenic mouse model of celiac disease, in which there is overexpression of human IL-15. Tofacitinib therapy led to a lasting reversal of pathologic manifestations. Currently, the tofacitinib is being considered to be used in celiac disease patients with a randomized controlled trial in the future. Another potential agent is called AMG 714, which is a human monoclonal antibody, and again, it's against IL-15. Three of the phase 2 clinical trial investigating this agent are underway in a patient with refractory celiac disease or those with non-responsive. These are the NCT's numbers. Moreover, a phase 1 clinical trial is underway in refractory celiac patients using the MIK beta-1 monoclonal antibody, which block IL-2 and IL-15. Number 12 is IL-10 agonist. IL-10 is one of the immune modulating interleukins secreted by T regulatory cells, and it may have a protective role in celiac disease when exposed to a low dose of gluten. So far, it has only been studied in the resistant group. Its role in the treatment of celiac has not yet been identified. Anti-CD20, anti-CD3. CD3 antigen is part of the T cell receptor complex that help activating both T helper cell and cytotoxic T cells. Theoretically, therapy with the anti-CD3 antibodies may suppress the gluten-activated T cells and therefore reduce the inflammation in celiac disease. Studies have identified that T regulatory cells can be induced in vitro by anti-CD3 antibodies and may promote the tolerance to the gluten. However, published data are lacking to support the use of this anti-CD3. B cells, as we know, play a major role in the pathogenesis of celiac disease through the production of various antibodies. CD20 is a B cell marker that is targeted by various monoclonal antibodies. However, it is known that the generation of IgA plasmablasts in the gut mucosa is not abolished by the CD20 antagonist. Those anti-CD20 may not be effective in the treatment of celiac disease. Although there is several monoclonal antibodies against CD20 being approved for clinical use, their role in the treatment of SID have not yet been established. Lastly, the CCR9 antagonist. It is a chemokine receptor known to be essential for lymphocyte migration into the intestine. CCX282 beta is a CCR9 receptor antagonist that was studied as a therapeutic option for celiac disease as well in the IBD, mainly Crohn's disease. Phase 2 clinical trial was performed in patients with celiac disease who followed a strict gluten-free diet for at least 2 years to evaluate the effect of that medication on villus height-creep-depth ratio of a small intestine biopsy specimen before and after the gluten challenge. These studies have been completed, but the results have not yet published yet, and this is the NCT number. given that the lymphocyte homing mechanism involving the CCR9 is not antigen specific. So there will be a lot of concern raised that this sort of agent could increase the risk of infection, particularly we are dealing with dirty GI infection. Conclusion. 1, the gluten-free diet is the only available treatment for celiac disease and will remain the mainstay of the treatment until a safe adjunct and alternative are available. Number 2, there is an unmet need for potential non-dietary therapies for celiac disease. And number 3, while many trials are ongoing or underway to explore non-dietary treatment for celiac disease, there is no consensus on the outcome measures in celiac disease trials. This is my references for the new treatment. And thank you very much for your listening.
Thank you so much, Dr. Maher, for this nice presentation. Really, we enjoyed it, and you came through a very important topic. So many asking about is there any treatment so far, so you concluded by the end of your talk. There is a couple of questions, if you could allow me to answer it and come to the stage, please, Dr. Maher.
Yes,
Okay.
sure.
They will take just a couple of questions because for the sake of the time. There is a question said, is there any significant relationship between vitamin D deficiency and celiac disease, especially in adults, or not?
As a causative for the celiac disease, the answer is no.
Good. Okay, the second question, how long after stop eating foods with gluten, symptoms will likely to get better?
There is a lot of study range between as short as 2 weeks and as long as 3 months. And then we have the celiac resistant and celiac refractory cases.
Excellent. Thank you so much. Please, can you introduce the last speaker if you would like?
Sure. Okay. So now we are moving to our last speaker, Ms. Nuha Barnawi. She is a colleague for us in the National Guard Hospital. She is working as clinical dietitian. She has tremendous training in special metabolic nutritional needs for disabled children and for rare metabolic diseases, as well celiac. Please welcome Ms. Nuha, and welcome to join us, Nuha. Please share the screen.
Dr. Nuha, please, if you could turn the microphone on. Okay, maybe Dr. Nuha, she's far away. Could we take a couple of questions, Dr. Maher, from the audience?
Yes, sure.
Okay. There is a question here. Is there any link between celiac disease and multiple sclerosis?
Yeah, yesterday we have a nice talk with autoimmunity, and there is a few published article about the correlation or incidental finding of celiac with those population.
Okay, so the audience, please, can you go back to our YouTube channel? The recorded session already uploaded on the YouTube, so you can enjoy and review it again, please. I think Dr. Nashi joined us now, so we might leave the stage for her.
Thank you, Dr. Bather. Noha, you will share the, okay, you share the slide, please. You can start it, Noha. Thank you very much.
Dr. Noha, the mic is yours now. You can start.
Yes, Noha, you the voice.
Can you hear me?
Yes, yes.
Yes, now is okay.
Okay, good. Thank you, Dr. Maher, for your introduction. It's really my pleasure to be with you today. So we will start with our presentation about gluten-free diet, inshallah, today. I will talk about the medical nutrition therapy for celiac disease. I will go through food map and celiac disease, gluten-free diet, in general about gluten, common food that contain gluten, gluten-free product, some myth about gluten-free diet, and how to read the label for gluten-free and some gluten-free product. And in the end, I will conclude my presentation with the support groups. So we will talk first of all about medical nutrition therapy for celiac disease. Our goals as a dietitian to promote optimal health, prevent and treat malabsorption, malnutrition, and other comorbidities to improve the quality of patient life. So whenever we have a patient referred to us as a dietitian, as an inpatient or outpatient, we will start our medical nutrition therapy by the nutritional assessment. So we will start first of all with we will take the nutritional related history. That means we will take the diet history, caloric intake, how much the patient taking from the calorie, macronutrient and macronutrient, especially calcium, iron, vitamin D and B complex. Also, we will check the knowledge and belief and the behavior of the patient. And sometimes we will check the factor that affecting accessing food for the patient. Then we will go to the biochemical data and result of medical procedure. We will check the gastrointestinal profile, which is the intestinal biopsy and the celiac antibodies. So we cannot start our intervention without those two. Then we will go to the nutritional anemia profile, which is folate and ferritin and B12. Then the vitamin and mineral profile, we will check thiamine, vitamin B6, vitamin D, copper, and zinc. And also we will go through the liver profile and electrolyte and renal profile. Then we will check the bone density screening. Bone density screening, it's need to be done within the first year of diagnosis. But as I said before, when we take the nutritional history, we will check the intake of calcium and vitamin D. So we will check the intake of those to assess the bone density health. Then we will assess the factor that will affect the quality of patient life. We will assess also the gastrointestinal symptoms, type, frequency, volume of bowel motion, abdominal pain. And in the end, we will assess some other diseases status. As we know, the celiac disease is an autoimmune disease, so sometimes it comes with other diseases. we will check the thyroid condition, and from the endocrine side, we will check mainly the diabetes sometimes, or let's say most of our patients, they have celiac disease with diabetes. Then after the nutritional assessment, we will go to our intervention. We will start the patient on gluten-free diet. We will give the patient multivitamin and mineral supplement if needed. As we said, sometime due to malabsorption, the patient needs some multivitamins and minerals like folate, niacin, vitamin B12, calcium, phosphor, and zinc. We will educate the patient about how to read the label, and we will educate the patient about food cross-contamination and hidden gluten food. And we will coordinate the care with other specialties if the patient need, like swallowing, sometimes physiotherapy. Then in the end, the monitoring and evaluation, we will monitor whatever we did before, the dietary compliance for the patient, the factor that affecting the quality of life, it's resolved or not, the gastrointestinal symptom, it's resolved or not. After that, I will talk about food map and celiac disease. There is some new study that combine the two, the food map diet and gluten-free diet. So we will see what we mean by food map. So food map is it's a stand for fermentation, oligosaccharide, disaccharide, monosaccharide, and bullies. All of these are a group of sugar. All of these are a group of sugar cannot be completed by just and absorbed in our intestine. They move very slow in the intestine and attract the water. Then they are fermented by the gut bacteria, causing gases in the large intestine and pain and discomfort in the intestinal wall. So that what worsens the GI symptoms, let's say in celiac patient and in other patients that complain of any GI issues. I will go through the food map one by one, so we will see what we will mean by each one. Fermentable, the first one, it's the process through which gut bacteria ferment the undigested carbohydrate. Then we will go to the oligosaccharide. Oligosaccharide, we mean by it the lactose, which found in dairies. The monosaccharide, sorry, the oligosaccharide, fructose, and galacto-oligosaccharides, which found in wheat, rye, and sometimes onion, garlic, and legumes. The disaccharide, what I mean by it is the lactose, which found in dairy product. The monosaccharide, which is fructose. And in the end, we will find the bullies, which mean the sorbitol and mannitol. Sometimes we find it in some fruits and vegetables. And also it's used in artificial sugars or artificial sweeteners. This is, let's say, with celiac patient that they have when they follow the gluten-free diet, still sometime according to Dr. Maher before, he said like the symptom will be resolved from 2 weeks until 3 months. But sometimes the patient come to our clinic and still complaining, and I suffer with my patient when I recommend for them low food map diet. It will help them to, let's say, reduce a little bit the symptom that come with the ingestion of the, the, the food map. So this is the food that need to be avoided in the diet, and that will help the celiac patient also. And for now, I will talk about gluten-free diet in general. What's gluten? Gluten is a family of a protein which is found in grains, including wheat, barley, and rye and malt also. It helps food maintain their shape, and it's act as a glue that holds food composition together. common food that contain gluten: pasta, noodles, bread, cake, pie. But I will not go through all of it. What's important to me: the thickeners, energy bar, and salad dressing, uh, and some soup, the one with best cream soup. Here we will talk about the gluten-free food, the natural gluten-free food, which is fruit and vegetable, meat, fish, and seafood, beans, and some dairies, all the dairy. We will go through the myth about gluten-free diet, some of what we heard from our patients. Wheat-free, it's mean gluten-free. So wheat-free not necessarily means gluten-free. We will find that gluten is the main protein, and we will find the gluten in the wheat and the whey and in the milk. So we cannot say if we have a wheat-free, we cannot say that's mean gluten-free. Oats contain gluten, and we need to avoid oat from the diet. We usually avoid the oat from the diet because sometimes the oat will be contaminated with wheat. But if we will have a product oat gluten-free, we can use it. Gluten-free diet is a healthy diet for our people. As I mentioned before, with the gluten-free diet, the patients sometimes have deficiency in mineral and some vitamins. So if there is any healthy person will follow the diet without any supervision, he will end with deficiencies in the vitamin and minerals. There is no need to be on a gluten-free diet if there isn't any symptoms. As I mentioned before, we have one classification of celiac disease, asymptomatic celiac disease. It's present without symptoms. So whenever the patient diagnosed with celiac disease, he needs to be in the diet. Lotions, shampoos, and creams and makeup contain gluten, and it's harmful to the patient. So we use all of this on our skin. Gluten to affect our body, it's need to be ingest. So if the gluten doesn't go through the GI system, we cannot say that it will harm. But in some cases, if we have like cut in our skin and we use a lotion or shampoo or whatever, it will go through the bloodstream and it may affect our gut. It's safe to share cooking pots after proper cleaning. That will prevent contamination. The gluten is really hard to be cleaned from the stuff, so the most safer way to keep the stuff of the patient. If we have a patient in our home with gluten on gluten-free diet, we need to keep their own stuff alone, and we will use another stuff. That will prevent from the contamination. Okay. Uh, just I will mention something about label reading. Whenever we have a product written on the package gluten-free, that means it's a gluten-free according to the FDA regulation. And if they write on it gluten-free, that means it's contain only 20 part per million or less of gluten. So how to tell if the product is gluten-free or not? We have here, let's say, nutritional fact. First of all, we will find a gluten-free label, or we will find the sign of gluten-free. So here we don't find it. So we will check for the obvious ingredient. If we will find, sometimes we will find like a hidden in the salad dressing, and sometimes in the thickener, and sometimes in the spices that they are putting. So here it's not clear. We will check also the allergen list. Some food they don't have allergen list. So here we have the allergen list. So we have milk, egg, soya, and wheat. So this is not a gluten free. This is a product. It's a gluten-free product. It will have the logo of gluten-free, and whenever we will check, we will find it's a gluten-free. There's also the logo that we will find on all the products, the gluten-free products mainly. Then this is the companies that we are using their product, the gluten-free product. Most common company that we are using in our hospital, Shar and Cristal. And when I'm going through the product, I saw Betty Crockers, and they have a lot of gluten-free product, which surprised me. So these some product that we can find on the market. So last, I will talk about the support group. So as the prevalence rate of celiac disease increased over the last year, a groups put together. We have like a website, some applications, and some social network. We have the Saudi Celiac Organization, National Celiac Organization. All of them contain information about celiac disease, gluten-free diet, and gluten-free product. Uh, and I found the application Saudi Food and Drug Authority. Whenever we have a product, we can scan it and we will see if it is gluten-free or not. Let's say we have someone, he don't know how to read the label, or he don't want to read the label, so he can use the application. The social network, we have a lot of on social media. We have a lot. They are talking about gluten-free diet and about celiac disease and about the product that contain gluten and the new product and the market. And we have some like accounts giving us our product in Saudi Arabia, that the product that we have, they can provide it for the patient. These three accounts. So any patient can order whatever. If he couldn't take the product from the company, or it's really hard to find it, they can contact this account and they will provide for them. Well, I don't think it's the same as the company. The price, it's a little bit less, and we can order also the other product from iHerb also. And in the end, I think we have these two cards, celiac card and gluten-free restaurant card. The celiac card is a discount card. Whenever the patient want to buy a gluten-free product, they can give them the celiac card and they will have their discount. And here for the gluten-free restaurant, it's a card. We can find it in celiactravel.com. It's mainly on 63 languages, so we can take it whenever we will travel to any place. If we want really, if we cannot talk the language of the country that we are going, so we can use this card to show them that we need to take a gluten-free diet, and that really will help. And the last, I will show you just a PDF from the Ministry of Health. Yeah, this is the PDF from the Ministry of Health. We will find on it all the hospital in Saudi Arabia that will give the gluten-free product for free, the basic gluten-free product, and we have some selective products. They can select the patient whatever they want. So down here, we will find the regions and the hospital and their emails. So anyone can share it with the patient, and anyone can contact the hospital and ask for the gluten-free product. But usually it's available. in the end, celiac gluten-free diet is a lifelong diet for celiac patients, so we need really to do our best to make their life easier. Thank you so much.
Okay, thank you very much, Noha, for your talk, as well your presentation. As usual, you give us a good hint about the products availability, as well some practical issue. What I would like you is, we have few questions. So Ms. Nawal Al-Mansour asks you, Noha, gluten-free diet is now a trend among some of the people. So is there any benefit to be on free, gluten-free for those non-celiac?
As I mentioned before, it's not a healthy diet to be on it as a healthy person, because with that time, the person will have some deficiency. So if they want to lose weight, they will lose weight, but they will end with a lot of problems like minerals and vitamin deficiency. So we will check the benefit. They can use the low carb diet. It will be more better.
Exactly, Noha. I remember a mother who restricted herself with GFD and then ended by severe B complex deficiencies, vitamin B. So I agree with you. If there is any question, if you can raise it, please. Okay. Sure. There is a question, Noha, about local factory for wheat, yani gluten-free. Do we have in Saudi?
Local factory. Yeah, I mentioned, I think, two in my presentation from the company that I mentioned. I think there is one of them. It's a Saudi. Let me check.
Sure.
I know it's not a Saudi. It's in Al Kuwait.
Yes, Al Kuwait. Yeah, it's
yeah.
So I think.
So from what I know, I don't think that we have in Saudi Arabia here.
Okay, there is no, but I think it is one of the projects from Al-Matahin wal-Ghilal, they will start by gluten-free, I think. So, yeah. Last question from Dalia. Dalia is asking you, Noha, about the compliance celiac patient to GFD diet. Is there any strategy to guide and convince the patient? This is the last question.
Guide and convince the patient. I think it's depend on the dietitian and her way to deliver the message to the patient. If the dietitian take the trust of the patient, he will listen to her whatever she will say. So we will give them whatever we have, and we hope they will be convinced and they will follow the diet. But
okay, thank you, Noha, for your participation. Thank you, audience. We, by the end of this sessions, we conclude our meeting. And thank you very much for your attendance. The attendance is exceeding or approaching 1,300 audience from different areas in the Gulf, as well outside. Some of the people from Egypt, Sudan, as well, they share with us and attending the activity. I'm happy to announce for the next year, inshallah, it will be physically, and wishing all of you 1,000 plus people to join us in our beautiful city in Al-Khubar in 2022. It will be 20th of May, inshallah ta'ala, when the COVID is no more, inshallah, exist. That time is the month of the celiac disease, and 18th of May is the Celiac Disease Day. Thank you for your participation. Thank you for my colleague. Thank you, respectful speakers, for your attendance and your time with us. I will leave now the talk to the final remarks from my colleague, Dr. Muad Al-Turaiki, for the president of the SASBGAN, and see you inshallah next year in Al-Khubar.
Assalamu alaikum wa barakatuh. Thank you, Dr. Maher, for your introduction and for closing remarks. Our colleagues, thanks so much for attending with us this amazing symposium, the first one. And as Dr. Maher mentioned, this will be the first, and next year, inshallah, see you, hopefully, inshallah, physically. I would like just to have some announcement about the SASBGAN activities. Now, we finished the second one in this year, the big symposium, first celiac. And also last week, we finished the series of the infant nutrition. We conducted 4 webinars. And now in front of you, there is announcement of the new, webinars that will be monthly conducted. The first one, what we call it, this is the single topic webinar series. The first one is cystic fibrosis, or updating the cystic fibrosis. This will be tomorrow at 9 o'clock. Regarding your questions, regarding the certificates, regarding the CMEs hours, I would like to just pay your attention for the following. For anyone working in Saudi Arabia who's have the Saudi Commission number, as you know, this is what will be uploaded in your account. If you have, your Mumaris or Mumaris Plus, and it is active, this means it have no problem since you register the proper or the right Saudi Commission number. Will upload that for you within 1 week, inshallah. For our guests and our attendees from outside Saudi Arabia, they have no Saudi Commission number. Those we can provide them with a certificate indicating that this activity has been accredited by the Saudi Commission with 8 hours and with the accreditation number and the date of accreditation. And you can give it in your country, either in the Gulf region or other region. You can give it to your country. Who's the institute there. They can count those hours for you, as we do sometimes if we get certificate from outside Saudi Arabia. So if anyone has a proper information regarding the name and the email and the Saudi Commission number, don't worry. For those, as we mentioned, from outside Saudi Arabia, will give certificates. Please, you can just send email how you would like to write your certificate, and we can send it as soft copy for you. Thank you again. Thank you. Special thanks for Dr. Maher, and special thanks for Dr. Dhafir al-Shihri. Dr. Dhafir al-Shihri is the one who's co-chairman with Dr. Maher for conducting this symposium. He's the one who's taking care of all of these technical issues. Also, you can follow the activities of SASBGAN through the social media, through our Twitter account, Instagram, and our YouTube, which also we can find this symposium and the previous symposia on our YouTube. Thank you again. See you inshallah tomorrow, and see you inshallah every month and next year for the second series. Thank you very much.
Thank you so much, Dr. Muad. Allah يعطيك العافية. يعطيكم العافية جميعا.